Welcome everyone, and I would like to welcome you at this session for the students. And in this session, we will show you how a day of an IR of an interventional radiologist look like. And this session is going to last approximately 1 hour. And during this hour, there will be 4 speakers, 4 young interventional radiologists, and each one of them will explain how his typical day in his work life looks like. So each speaker will talk for 8 to 10 minutes, and after each presentation there will be time for questions, for a short discussion. And if you have some questions or some for the discussion, please enter them in the Q&A area, which you can find at the bottom of your screen. And so this session is moderated by Dr. Sara Proto. She's an interventional radiologist from Tampere, Finland. And by me, Rok Deisman, I'm an interventional radiologist from Ljubljana, Slovenia. So without further ado, we should probably start with our first presentation. And this first presentation is titled What My Day in the IR Suite and Outpatient Clinic Looks Like, and it will be given by Dr. Jan Jansen. So he's an interventional radiologist from the Netherlands, and he's working in the field of vascular malformations. So Jan, would you do the honors and open this session for the students?
Yes, thank you, Rok, for the invitation. Well, and I'm gonna talk for a few minutes about what I'm doing here in this hospital, and mainly focusing on how I feel that the work I'm doing mainly consists of teamwork, being part of a team. A little something about myself. For a year now, I've been working in this hospital, the Radboud University Medical Center in Nijmegen, the Netherlands. It's one of the university hospitals here. We, in our interventional radiology department, do some general IR. We do vascular intervention, non-vascular oncology, all things you'll be seeing something about later. But we also have a special focus on vascular malformations, with some examples shown on the right. But what I mainly want to talk about is how my week, what I do in a week. So on Mondays, for me, it's just a normal day of general IR. Half of the time here and half of the time in a smaller hospital nearby. We have a cooperation with that hospital since they only have 2 interventional radiologists. So every week, one of our team goes over to that hospital to do some procedures over there. But then on Tuesday, it gets more interesting for me. Tuesday is a day in which I go to the outpatient clinic. I see my own patients referred to me from all over the Netherlands. There I talk to the patients, get the diagnosis if possible, and discuss with the patients, of course, the kinds of treatment we have. For the treatment, we have 1.5 up to 2 days of time in the angio suite on Wednesday and Thursday. So we do all our procedures under general anesthesiology, and I'm going to talk not so much about that, but that's what we do on those days. Thursday afternoon is filled with a multidisciplinary board. I'll get back to that later. And Fridays are back to general IR for me or diagnostic radiology, just where I'm needed. Well, something about vascular malformations. Well, some of you might know it. Vascular malformations, you've got venous malformations, lymphatic malformations, and arteriovenous malformations, which are relatively rare, but important to mention, benign entities. The government in the Netherlands have said that treatment of those lesions can only be done at centers of expertise. In the Netherlands, we've got 4 of those centers, of which the Radboud UMC is one. just looking abroad, in the whole of Europe, you've got the Vascular reference network, which is a reference network for everything about the treatment and research of rare vascular diseases. And within this reference network, there are a lot of smaller working groups, subgroups, of which the Vascular working group focuses mainly on vascular malformations. And within this working group, we cooperate on behalf of multi-center studies, but we also discuss with each other treatments for difficult cases, and if necessary, we can refer patients to other centers, or they can refer the patients to us if they think that we're a center of choice. Within our own center, we have to. Well, we work mainly in a multidisciplinary approach. For that, we have the Hekelvan Center of Expertise. I'll get back to that as well, because a lot of vascular malformations need to be seen by multiple doctors for a treatment. Some lesions will be treated with drugs. Some lesions will be treated with an interventional radiology method like embolization, and others will be operated on by a surgeon. For example, I'll get back to this patient of mine, if the video is working. It was working a moment ago. This man presented to us with a large swelling on the back of his head. He was operated on in another hospital because they thought he had a lipoma. So they cut open his skin and it started bleeding really hard. They did manage to keep him alive, but then sent him over to us for the treatment of his arterial venous malformation. And what we do is, in multiple sessions, we try to embolize it, but once it's completely embolized, you still have a large mass on the back of his head, because all the coils we place and the thrombosis that occurs will remain as a large mass. So this cannot be treated by interventional radiologist alone. We also need the help of a vascular surgeon, or in this case, a plastic surgeon, so he'll have a normal shape of his head. The other way around, the surgeons also need us, because if we don't embolize first, it will be a massacre for them. Well, we work together in a large team, and everyone on the right and on the left shown is part of it, and a lot of things speaks for themselves, I think. But through all of these members of our team, I think, except for the lower part of pathology, physiotherapy, and psychology and pain team, people are referred to us. If necessary, we refer the patients to other parts of our team. But also really important is that within the pathology department, we have someone who is specialized in vascular malformations. So if we think a lesion looks different than we expect, or is not responding well to a treatment, we can do a biopsy, and she is specialized in the vascular malformations, and she can check whether there's a specific DNA alteration within the lesion which is causing the lesion, because some lesions with certain DNA alterations can be treated really well with drugs. So all these levels work together in order to give a patient the best treatment possible. One of my final slides, I think what makes my work most interesting and is that we also do an outpatient clinic. That might be standard care in other countries, but in the Netherlands that is not the case. Interventional radiologists here usually don't go to the outpatient clinic themselves. What for us is really important, that when patients are referred to our center of expertise or to us directly, we want to see the patient for ourselves, because I think it is really important when you do a procedure that you select your own patients and not just do a procedure because someone else says, oh, you should embolize the lesion, and that's that. You should agree with it, or maybe you think something else is better, and then you got the opportunity to propose that. But another thing is that if you see the patients for yourself, then you build up a relationship, or a trust relationship with your patients. And I think it's always important, but certainly in patients with lesions like this, because a lot of these patients will be coming back regularly for the rest of their lives, because most lesions cannot be treated completely. So more or less they will remain some complaints, and they should feel safe to tell what's wrong, whether something we've done has helped or not, and that only works if they really know you personally. Something else, well, the multidisciplinary board, I don't want to get into that very much, because I think everyone knows that, and that's not really special. There we discuss the patient's files, and if necessary, we refer a patient within our own team to another specialty. But following our multidisciplinary board, what I do think is special is that we have a multidisciplinary outpatient clinic, where we have room for up to 4 to 5 patients every time. And it works, and you see it on the lower right of the screen. There's a patient with his wife, and we are entering the room with our entire team. So it can be sort of comedy looking sometimes, or sometimes even intimidating. But what we do is that we all enter together. We at once, all the same time, discuss with the patient and with each other what we think is the case, what should be done, and who would be the best discipline to treat the patient. And if so, the rest leaves the room, and for instance, the surgeon or the interventional radiologist stays behind and discusses further with the patient about the treatment plan, and makes the next appointment. And that helps us. Well, a lot, because when you only discuss a file of a patient, it's sometimes difficult to see the total picture. And when you've got the patient in front of you, that, well, for us, that works really well. But on the other hand, the Netherlands is just a small country. So for us, it's not that hard to ask a patient to come over, maybe compared to other countries. To summarize, I think that specialized care, something like the vascular malformations, that it often requires a multidisciplinary approach. I think I stated the importance of patient selection and referral, but because it requires a multidisciplinary approach, and you need to be able to refer patients to other specialists if you think that they're better off over there, it's really important to maintain a good relationship with other specialties. Yeah, I think that's what I want to say about it. Some final thing, not on my slides. There's in the on-demand section of Surgery is also a really good session about vascular malformations for those of you who are interested in it. And with that, I think I have to give the controls back to you.
Thank you. Thank you, Dr. Jansen. So do you have any question to Dr. Jansen about this presentation? There is someone, let's see, not yet. I wanted to ask you about how many cases of vascular malformation do you have per year?
With our entire team, we see about 5,000 patients. And last year we did 550 or 560 embolization procedures.
That's impressive. And so you have, of course, sometimes patient coming back. So how long do you wait with treatment?
What we generally do after procedure is that we wait for about 6 weeks to see the effects of the procedure. So after 6 weeks, we have a phone call with the patient to assess whether, well, we've done enough, or we need to do more, or didn't help at all. And then we reassess if someone needs another procedure. Then mostly it's about 3 months in between we do the procedures. But in some cases of people with AVMs, we need to be a little bit more aggressive, and then it's about 8 weeks in between.
Yeah, of course. And then one question from the audience. So would you be able to talk about a case where you had to think outside the box due to unforeseen challenges?
Yeah, I think a lot of patients for us, we have to think about a box. We have a few patients with large AVMs in the face region, some with quite a large mass effect as well. They bleed regularly, and that for those patients we have an entire protocol here in the hospital. At the operating rooms, they have got their own trolley with stuff we need when they enter here with the large bleeding. So when they arrive, it's always out of the box because we never know what is going to happen, and everyone comes running to the angio suite. We have got, like, there are 3 to 4 anesthesiologists who will be called when they come in, especially they, even if they're not on call, because they know how to do this. And the same goes for the pediatric surgeon. And what we then do is just try to manage, at first, try to manage the bleeding, which can be just by compressing for a long time or placing some stitches. But afterwards, as soon as it stops, we have to try and place some needles as close to the nidus as possible and then embolize. And that can be challenging, especially when it's in the mouth region or in some other patients intraorbally.
Yeah. Yeah, of course. So we have to go ahead because we are already a bit late. So next speaker will be Dr. Petroli, and she will speak about interventional radiology suite, where the magic happens.
Hi, everybody. My name is Dr. Bhavna Petrola. I'm an interventional radiology fellow from Imperial College in London. So I'm going to talk to you about interventional radiology, where the magic happens. So what is interventional radiology? It's magic. It's actually a bit more complex than that. It is image-guided intervention. We utilize micro equipment and techniques to actually perform image-guided surgery. We can be used as an adjunct to or alternative to open surgery, but also we can be an adjunct to surgery as well. Most of our techniques are based on the Seldinger technique, and that's sort of what most of IR is based on, really. So what is a Seldinger technique? The Seldinger technique was first described by Dr. Ivan Seldinger in 1953. The picture here shows you that he puts a needle into the vessel, a wire to follow through the needle comes out, you make a small skin incision, and then over the wire, because that's your access point, you'll then put a tube or a catheter sheath, whichever you put in, and that is the Seldinger technique. Now that has been modified, and that's basically the underlying method of what we do in intervention. So, interventional radiology, it actually encompasses all specialties in medicine and surgery, but it can be broadly categorized into vascular, non-vascular, and therapeutics. This is sort of this is how I've categorized them. So vascular would include things like angiography, venography, venoplasty, angioplasty, fibrinolytic treatments, embolization, vascular access. Non-vascular includes sort of hepatobiliary, nephrostomy, ureteric stenting, GI stenting, biopsy and drainages. And the therapeutic part is things like specific target embolization, say for prostates or for uterine arteries, tumor ablation when we actually, administer chemotherapy or radiotherapy directly into the tumor. So it's quite broad and it covers a lot of this, including emergency medicine as well. So what's a typical day in IR? There's no such thing as a typical day in IR. So my day normally starts at 8 o'clock. I come in early and I actually prep all the cases for the day. So there's a set of cases that are prepped, and then we have a board round at 9 o'clock where we discuss it with the nursing staff, the radiographers, and we plan how we're going to how the day is going to be organized. The list can include elective patients, outpatients. It can include inpatients. You can also have emergency patients as well. Some cases are simple and basic, like biopsies, drainages, and some are slightly more complex. They can be sort of post-operative patients which are high risk under general anesthetic. Most procedures in general are actually performed with the patient awake under local anesthetic. So we would use something like lignocaine as a short-acting local anesthetic. Sometimes we do use benzodiazepine, we do use bupivacaine as a sort of a slightly longer acting, but generally lignocaine is more than enough for us. We can give sedation. It's conscious sedation with something like fentanyl and benzodiazepine like midazolam. Again, both of them actually are a good combination. We do quite a lot with conscious sedation. Some cases are under general anesthesia. And again, those are sort of either higher risk patients or patients actually who are very, very unwell. Most of interventional radiology is performed under a combination of ultrasound on its own or fluoroscopy or a combination of both. But generally, this is sort of how a list will plan out. So this week's highlights. I thought I'd go through a few cases which have happened this week. So the first case is actually of a lady who is 76. She presents with critical limb ischemia and she had an abnormal duplex. And so she was one of our day case elective patients. And so the initial thing what we did with her was we gained vascular access. So it was actually a right common femoral artery puncture under ultrasound guidance. We then inserted a sheath, which is based on an introduction device where it has a side arm and a central port, which is a hemostatic valve, and we're able to take pictures and pass wires through them. So the picture on the left of the screen would show you that it's actually a basic angiogram. You see the superficial femoral artery, the popliteal artery, and the anterior tibial artery, which I've labelled, and in red you can see where the stenosis is. And so what we did, we traversed the stenosis using a combination of wires and catheters, and then following that we performed balloon angioplasty of the popliteal artery, and that's the second picture you can see there. And then afterwards, after you do an intervention, you do a follow-up angiogram just to confirm that what we've done is appropriate, and also there's no other adverse complications. And so the post-angioplasty angiogram shows actually the stenosis has been treated. So she successfully had her leg treated, which is quite a normal everyday case that we do. A second case I'm going to talk to you about is renal artery stenosis. This is actually a very interesting case. It's a gentleman who's 87. He had a background of renal cell carcinoma, and he has had a previous nephrectomy. So he's only got a solitary kidney. Now, when the solitary kidney, you've got to be very careful because obviously this is now slightly a higher risk case. So with him, he had abnormal worsening renal function, and he had an MRI done which showed there's renal artery stenosis. So they wanted us to treat this renal artery stenosis to prevent him from going on to full-time dialysis. And so we did was an angiogram. So it was via a right common femoral artery again. We used a pigtail catheter into the aorta, and we did a pump run, as you can see over here on the first picture. Now, I don't know if you appreciate, but there's a red box with the black arrow on it saying that where the stenosis is. So there's actually osteal stenosis of the renal artery. Now, this was then treated with using sort of a wire through a wire technique, and we ended up traversing the stenosis, securing position within the renal artery and the renal pelvis, and then following that we actually deployed a balloon mounted stent into the ostium of the occluded stenosed renal artery. And then the follow-up angiogram on the right shows you actually this has been resolved. So there's been reopening of that stenosis. So we've actually treated this gentleman, preventing him from going on to dialysis. And we'll see how it comes out with the rest of that. The next case I want to talk to you about is cholangiocarcinoma. I'm sorry, my screens have actually, it seems like my slides not working very well there. This is actually a gentleman who had, a 67-year-old gentleman who presented with biliary sepsis and very unwell. Now with him, he had a background of duodenal cancer. He was treated initially successfully, now he's reoccurred. So the initial CT shows there's extensive biliary tree dilatation. On the CT you don't see it, but he's got a reoccurrence at the duodenal cancer, which is causing the dilatation. So for him, we actually reviewed the scans, and then we performed a PTC, which is a percutaneous transhepatic cholangiogram and drainage. So this is actually a segment 3 duct of the liver was actually accessed under ultrasound guidance. We confirmed with a cholangiogram, and then a wire and a catheter were negotiated into the partially opacified common bile duct. And then once positioned through the duodenum was secured, we then were able to insert an internal external biliary drain. So the internal external biliary drain has lots of side holes, and it allows forward flow of bile from the site at the level of obstruction through the tube into the duodenum, so forward flowing, but also the side holes that go above the actual stenosis. And that what happens is there's bile is able to drain out from the port and into a bag as well. So it's an internal external. So this man then eventually had his bilirubin came down and he became slightly better and was able to then go on and have further treatment for his duodenal cancer recurrence. So, okay, and the next case I've got is a broken central venous line. Now, this was actually a very interesting story, actually, a quite fun case, actually. It's just this is actually a lady who had a tesserae line, which is a dialysis catheter inserted. She'd had it for many years, and then she had a transplant given to her, transplant kidney given to her. So therefore, she didn't require her to have any, didn't require the tesserae anymore. So with her, the surgeons took her to theatre to take the line out. Now, one line came out quite easily. There was no concerns. But the second line fractured on the way out. Initially, they thought it was quite secure, but on the radiograph, they noticed it was moving quite a bit. So they wanted us to try and retrieve it. So what we did, we took a pre-radiograph, which showed that the tube was actually in the SVC, and it's broken. When we put it onto the angio table, we did a quick fluorograph, which showed the tip has further migrated and is in the right atrium now. So we had to now fish this out because this is going to be a source of a thrombogenic source, and she'll become quite unwell. So with this, we actually did a right common femoral vein puncture. A sheath was inserted, and also using a reverse curve catheter, we manipulated it into the right atrium and then twizzled so that actually we tried to catch the actual free floating line to pull it down. I know many of you are probably thinking why we didn't use a snare device, and there's a reason, because we're in the right atrium. We cannot use a snare device there because I don't want to pull half the heart out. And so what we did, we negotiated and manipulated the actual free floating line into the IVC, and then we're able to snare it from the bottom, and the line was retrieved. So that was quite interesting and quite challenging. It took us quite a while. And you can see on the post-procedure radiograph, there's no line there, it's all out. So IR can sometimes even go fishing. Fine. So I've got my last case now, which is actually a ureteric stricture. It's a gentleman who came in very unwell. So there's a gentleman who came in very unwell. He's got a blocked kidney due to a stone causing an infection within the renal pelvic seal system. There's lots of dilatation, lots of inflammatory stranding. So this gentleman already by my colleagues has had done a nephrostomy, which is drainage of the kidney externally. So we've decompressed the system and alleviated all the pus out of them. Now, because there's a stone, actually, they weren't able to get to it, so they wanted us to put a ureteric temporary stent in. These are plastic tube stents. So what we did then with him was we brought him into the IR suite. With anything, you always take a pre-radiograph. So the first picture shows there's actually a pigtail nephrostomy in the left kidney. We injected contrast. As we injected contrast, we can notice there's a fitting defect within the proximal ureter. That is a stone that's causing the obstruction. Then we went on to take the pigtail catheter out over a wire. We negotiated a wire and a catheter into the ureter, past the stricture and into the bladder. And over that, we inserted a double JJ stent into the renal tract with the top pigtail in the kidney and the bottom in the urinary bladder. So, in summary, IR is fun. It's a multi-modality, hands-on practical specialty. We're able to perform quite simple or complex procedures through a very small incision. It's rapidly evolving and highly rewarding, and we do make magic happen. We can do a lot. Thank you very much for listening. Any questions?
Thank you, Bhavna. You had a really great presentation. You showed really how versatile IR is. So when you are in interventional radiology, you can in the same day do oncology and then urology patients and then vascular surgeons patients. So it's really, really versatile. You never get bored, I think.
No, absolutely. I think that's the big thing. You make magic happen, and it's definitely an evolving specialty. No one day is the same. And even if you think it's the same, there'll be a complication that'll catch you out.
So you can go probably ahead because we are again a bit late.
Sure.
And we will continue with Dr. Rock Datsman, and he will speak about my typical Wednesday MDT meetings and on-call duty.
Okay, thank you very much, Sarah, for the introduction. So first, let me introduce myself. Okay, so I'm a 36-year-old interventional radiologist. I finished med school in 2010 and finished residency in radiology 3 years ago. So you do not have to be an old guy to enjoy the interventional radiology. You can be relatively young and still perform awesome procedures. So I work at University Medical Center of Ljubljana. This is in a small country of Slovenia, somewhere in Central Europe. And I work as an interventional radiologist 3 days a week and abdominal radiologist 2 days a week. And when I'm interventional radiologist, I perform all body IR procedures. So I'm general interventional radiologist, but I do have my own special interest, and this special interest is treating oncologic patients with interventional oncologic procedures. So I would like to show you how my typical Wednesday looks like. So in Slovenia, we usually start work in 7:30 in the morning and finish it at around 15 or 15:30 in the afternoon. And the Wednesday is my MDT, is my time for the MDT meetings. So I don't do any interventional work on Wednesdays. I don't do any reporting. I just join the MDT meetings, and there are several of them. So this is my normal time at work. However, Wednesday is special, so from 3 o'clock in the afternoon till the 8 o'clock in the morning next day, I'm on call. So this means in this time I perform certain urgent and emergent procedures that cannot wait for the next day. Typically, I do this 3 to 4 times a week. There are approximately 8 interventional radiologists at our department. So the MDT meetings are really important, and thank you for Jan for explaining all about the MDT meetings. There was a time when interventional radiologist was not really present at these meetings, or was only present there, to review the images. However, now the interventional radiologist is an integral part of these meetings and is an important member of all the MDT meetings, especially the oncological multidisciplinary meeting. So for example, this is how our liver MDT meeting looks like. We have a gastroenterologist, oncologist, then we have liver surgeon or hepatopancreatic or biliary surgeon. Then we have a radiation oncologist present, and of course, interventional radiologist. And it's between those 4 doctors who decide which treatment is best for certain patients and for his disease. And this is how my Wednesday schedule looks like. So at 8 o'clock in the morning, I start with the renal MDT meetings. Here we discuss patients with renal tumors. And here we get referred to as renal tumors that are suitable for ablation. Then we discuss patients who have renal stone disease and have their lithotripsy procedures planned. And then we also discuss patients for diagnostic biopsies or for the insertion of nephrostomies or ureteric stents. So this is a short meeting, usually lasts about half an hour, and then we proceed to our bigger meeting. This is HPB meeting. So HPB stands for hepatico-biliary, pancreatico-biliary MDT meeting. So here we discuss patients with liver tumors, with pancreatic tumors, and with the bile ducts and biliary system disease. And this is where the majority of our patients are referred to us. Here, we do a lot of procedures in these patients. So we do a lot of treatment of liver tumors, either with ablation, chemoembolization, or radioembolization. And we do a large amount of diagnostic biopsies and also interventions for biliary pathology. Following that, There is a liver transplantation MDT meeting. So here are discussed patients who are planning to have liver transplantation or who already underwent liver transplantation and are followed up by this MDT. And usually from this MDT meeting, we get patients with liver tumors who we treat in order to bridge them to transplantation. So we try to keep the tumors small, on the small size, so they can undergo the liver transplant. Or after liver transplantation, some of these patients can have certain pathologies, certain complications. Usually it's stenosis of the biliary ducts, and we treat these patients with either balloon dilatations or drains and or some other procedures. And lastly, we have our last meeting is neuroendocrine tumor meeting. So neuroendocrine tumors are, we are one of two centers who treat patients with neuroendocrine tumors in Slovenia. So here we do a lot of diagnostic biopsies because the biopsies are really important in these patients. This is the only meeting where we get really small amount of patients, but still the interventional radiologic treatment of especially liver metastasis is gaining an importance in these patients. So we regularly attend this meeting. So this is it for my like a normal day of interventional radiology. So normally I would finish work at 3 o'clock or 4 o'clock in the afternoon and go home. But as I said, this is my on-call day. And here I start with my on-call duty. So the interventional radiology is an essential clinical service in the management of emergency patients. And there are some procedures now that interventional radiologic procedures that should be present at every important hospital. So what we do at our department is we offer 24/7 interventional radiology care, and we perform all the urgent procedures that are for the patients that are either have organ-threatening disease or life-threatening disease. And this is probably the hardest part of the job, but it's also the most interesting part of our job. So what kind of procedures we do here? Usually we do drainage procedures, so in patients with fluid collections, abscesses, and nephrostomic insertions. You saw before, Buana explained in great detail this procedure, and also some ureteric stenting. Then we also do some peripheral vascular interventional for limb ischemia, and vena cava filter insertions in patients with pulmonary embolism. And we also manage some dialysis access in on-call setting. And the thing that it's probably most interesting, but comes up a bit rarer, is management of bleeding. Most of trauma patients and GIT bleeding patients from the lower gastrointestinal tract are now managed by interventional radiology. And of course, treatment of aortic ruptures, either aneurysmatic ruptures or traumatic ruptures. So here's my typical Wednesday. This was the Wednesday, the August 12th. So we started at 3 o'clock. We had a 71-year-old patient for the nephrostomy insertion. She had a blockage in the urine outflow after the radiation due to the rectal carcinoma. Then we performed the US-guided abscess drainage in patients after Whipple procedure. So this is a major abdominal surgery procedures with quite often we have complications after these procedures. Then we have a nephrostomy exchange. So this was a patient who already had inserted nephrostomy, but it blocked, and we exchanged this nephrostomy catheter. And then the fourth patient was a 33-year-old patient who was a victim of a motor vehicle collision. He was hospitalized in the ICU, and he suffered a pulmonary embolism, and that's why we have to insert a mesh filter in his inferior vena cava to protect him from further pulmonary embolisms. And the last patient was patient After liver transplantation, he had stenosis of anastomosis, blocked a blockage in a bile duct systems, and so we inserted the percutaneous drain into his biliary system. So after this patient, we left the hospital at about 9 o'clock in the evening. We went home, go to our bed, and then at 3 o'clock in the morning, our gastroenterologist called. They had a patient, 67-year-old female patient. After surgery, sorry, this was not the right hip fracture. So this was patient who had a hemorrhage into the lower gastrointestinal tract. And here on the CT, you can see she was bleeding heavily in her ascending colon. And the gastroenterologist couldn't stop this with endoscopically. So we performed the interventional radiologic procedure. You can see bleeding here from the branch of the superior mesenteric artery. And we performed embolization. We stopped this bleeding with small coil, and this patient then stabilized and was treated successfully. So you can see the interventional radiologist's work is quite interesting. You perform procedures. You're almost like a minimally invasive surgeon. You do some reporting, and you also attend the MDT meetings. It's not always easy, but it's most definitely always fun.
Thank you so much, Rok. This was, again, really interesting. I guess we have to go ahead with my presentation because it's quite late already. So I will be speaking about the organization of my departments, neuro and body, and I have few cases. I will go through my presentation quite fast because we don't have any more than a few minutes. Next slide. I don't have any disclosure. So in my department, we have two different interventions, neuro intervention and body intervention, even though we are in the same department. We moved at the beginning of this year in a new facility, and normally neurointerventionists, they are doing brain aneurysm, stroke treatment, AVM, while body interventionalists, and I'm now doing mainly body, are doing a critical limb ischemia and claudication, interventional oncology, so endovascular and percutaneous, aortic aneurysm, bleedings, and interventional urology, even, for example, fibroids in the uterus, and so on. We can move to the next slide. We have now a really new department with 5 angio suites, which is quite big department even in Europe. So we have 2 neuro angio suites where we have biplanar machine, then we have 2 body interventional suites, and then 1 hybrid where we do mainly aortic procedures. And then we have also 1 operation room for open surgery, because we are in the same department with vascular surgeon. We're working with them quite tightly. And then next slide. So here we have a typical case we can have during the day. So elective case, in this case, we have a 66-year man. During a normal CT for other problem, we found a 3.2 centimeter renal artery aneurysm. And then we decided with the patient and with the doctor who was treating this patient to treat the aneurysm with embolization. You can see here it was quite big. And we have 2 different branches coming from the aneurysm. So to preserve the vascularization of the kidney, you have to try to embolize it without closing the branches. Next picture. So you can see here we have 2 guide wire going from the superior anterior branch and the posterior branch. And through those, we put 2 different stents. We had an expert stent and a live stent, which are stents we use in the body, and also, for example, in limb interventions. And then we through the strut of the stent, we put it a micro catheter, and through the micro catheter we embolized with coils. And at the end, you can see that the aneurysm is well embolized. Next slide. So here we have a different kind of intervention. This intervention normally happens during the night or in the weekend. So when you are home doing something different. And this is a bleeding, a duodenum ulcer of a 67-year-old man. And a gastroscopy was performed, but the bleeding did not stop. So the patient was referred to us. I actually did this patient, and I remember it was night. I went there and I expected to find a gastroduodenalis bleeding, and I found it, and I coiled it. In this case, you have to coil always after the bleeding, and all the artery from which is coming the bleeding. So also after the bleeding, because you can have a backflow. But at the end, it looked perfect, and I went home. The day after, next died. Anyway, the day after, he had hemoglobin drop and pain, and so we did another CT, and as you can see, we see again bleeding. So I wasn't at work that day, so my colleague did the angio, and he saw that there was still bleeding coming from other vessels. And as you can see, or maybe you cannot really appreciate that, but anyway, there were branches coming from the splenic artery and branches coming from the SMA, giving again from which bleeding was coming. And so my colleague was actually using, in this case, liquid material to embolize, and also a plug, MVP5 plug, which stopped the bleeding almost straight away. Next slide. So here we have another kind of emergency. This is an occlusion of iliac vein. And in this case, probably we have a chronic situation and then a thrombotic situation over it. So what we do normally is that if we have occlusion over the femoral vein, so in the iliac part of the venous system, we do thrombolysis. In this case, it's a woman, 57-year-old, and we did 2 days of thrombolysis. And after that, it's anyway quite the first picture is after 2 days of thrombolysis, so it's not so good. And then we inserted 2 stents, and then you can see, you appreciate a really good flow. Next slide. So this is a quite an interesting case I did. It was an 80-year-old man. He had just hypertension, a smoke history. And we knew he had aortic aneurysm of 72 millimeter, and he was actually scheduled for a grafting in our institution. But he came back because of pain in the abdomen, and because of that, we did a CT where we saw a ruptured aneurysm and a left iliac artery occlusion, which was a new finding. In this case, you cannot use a normal graft for stenting the aneurysm, but you should use a monoiliacal graft because you don't have the other iliac artery. So we didn't have this kind of graft. So, next slide. Here you can see, you can appreciate actually the aneurysm and the iliac artery, which is occluded. Next slide. So we decided to use the upside down Gore excluder contralateral leg technique, which is quite a new technique, and not so new, but anyway, we don't use it every day. So you use a part of the graft that normally goes in the iliac artery, and you turn it, you break actually the device, you turn it, and then you use it to exclude the aneurysm. This is something you should not do at home, if you can say that. So you have to be really careful to do that. But then if you can do it, normally it works. So we did that, and then we continue with the contralateral leg, and then we put a cuff proximally on the neck of the aneurysm, and we had a really good result. Anyway, we saw a type 2 endoleak, which is an endoleak coming from a lumbar artery. So we did a control in the CT the day after. And next slide, that's what we saw. Next slide. Can I have please the next slide? Thank you. So that's what we saw. You can see from the CT the blush of contrast with the like leak type 2, and also our angiogram where you can appreciate the leak angiographically. Next slide. In this case, what you do, because it's coming from the inferior mesenteric artery, is going to through the superior mesenteric artery, through the Riolano arcade, and then through the IMA in the sac, and then you occlude the lumbar artery and the IMA. Of course, always everything can happen, and in this case, even though I managed to go to the lumbar artery, occlude it with coils, then while I was putting some glue, this glue came back too proximally, and so it occluded part of the Riolano arcade, and I could not anymore pass through it to the inferior mesenteric artery, so I could not actually treat this leak. Next slide. Yeah, next slide. And so at the end, I tried from iliac internal artery through another lumbar artery, but it was really, really tortuous, and so it was not possible. Anyway, we had a good result because we checked it afterward, and the aneurysm was shrinking and the hemoglobin was good, so we stopped with the treatment. Next slide. So this is what a night can look, or a day. So our work is so versatile, our work is so interesting, because we can really jump from a leg to an arm in the same day. That's why I really love it. And I'm really happy that you are interested, that you came here to hear from us about our specialty. Thank you very much.
Thanks, Sarah. Hi, Sarah.
Because
yes, of course.
From the audience, there was a question. So what you can do if you are interested in interventional radiology, of course, it depends in which state you are. So what's the regulation of your hospital? But for example, in our hospital, we can take students if they want to come and see what we do. We have just to make some permission from them, for them, and they can come and visit and stay with us even 1 month, 2 months. And we are able also, not now with the Corona pandemic, but in our hospital, in Tampere University Hospital, we are also able to take a student from abroad. One student at a time, but we have done it before, and we will do it after the Corona pandemic is over. So that's my answer. I don't know, Rock, Bhavna, what about your countries? Jan-Jaap?
So we can start with Jan-Jaap.
Well, the hospital I'm working right now, I don't have seen any students from other hospitals yet in our department. But in general, you can always, I think people can always come over if they want. You can just contact, and I don't think that's just limited to our hospital. I think in every hospital, people are willing to share the passion for their work, because what we do is really nice work. And yeah, so I think that you can just reach out, send an email, and ask if you can come over. but that's just the part of being in a hospital. There, you know, there's always the things of where do you stay when you go to another country and things like that. I don't know what our hospital can do for a student or what the student has to do for themselves. I'm not sure.
So in England, we actually do get students sometimes over, but mainly it's for observerships. In IR, we have had a few summer students, summer junior doctors from abroad. I think mainly it's in the observership, and sometimes there is an issue with the medical legal aspect of it because of observing cases and stuff like that. So some cases you can't always go into. It might be from outside. So our students sometimes don't come into the room either, or not into the IR suite. So I can find out and let people know from our point of view. But we have had a few from different countries come across, but it's only observerships, nothing more than that.
Yeah, of course.
So in Slovenia, we've had a number of students from neighboring countries, usually from countries from the former Yugoslavia, also some from Italy. Usually students contact us directly. We unfortunately do not offer any facilities to stay in there or there, but what we offer is, you know, an observership that can be either from 7 o'clock in the morning to 4 o'clock in the afternoon, or whole day. It all depends on how, you know, nothing is set in stone, all can be discussed. So if you have any questions, you're free to, or if you're interested in performing observership at our hospital, send me an email. And the ETF subcommittee is working heavily on, you know, standardizing, having a list of hospitals across Europe where students will be able to perform the internships or the observerships. And this will probably become a reality in the next 6 or 12 months.
Yeah, if I can add, is that ETF, as Rox said, is really working. Of course, this Corona problem gave us a stop, but you always can, in your country, in your hospital, try to write to the head of the department, or if you know someone in IR, a friend, a fellow, or someone, then you can write to him or to her. And also for us, I mean, me, Roque, and the ETF members, you can write to us. We are trying, of course, to help you, to help you with this matter. But unfortunately, I think there is no scholarship for that. If you don't find yourself something in your hospital, in your country. Yeah.
Exactly.
Otherwise, you can write at etf@circe.org in order to get in contact with us. It's an email address where you can drop at any moment all your questions, and we will try to come back to you as soon as possible. Thank you.
Okay.
And the one who was speaking is Gigi, who is our new president. So if he says so, then you have to do that.
Okay. So thanks everybody for joining this session, and have a nice evening, and we all see you tomorrow at the third day of the CIRSE.